Thank you so much for having me. Are you ready?
Oh, we
I'm
are.
ready.
Okay, I'm going to switch the screen.
Okay, dear.
Go ahead.
All right. So thank you so much for your kind invitation. And it's an honor for me to be here with you today and also to follow Dr. Rob Lee's presentation. So today we will continue talking about growing bone, and we will discuss non-surgical midfacial development in adults. So we will, obviously, if we talk about non-surgical expansion in adults, we have to talk about using temporary anchorage devices. So we will talk about what we have, what kind of treatment we can do with these devices in terms of expansion. We also will talk about airway implications, periodontal perspective, as well as aesthetic perspective of it. First of all, I would like to start my presentation with talking about the anatomy, about the role of the maxilla. And we have to remember that maxilla plays a very critical role in our body. It is the center of your face. It is part of the midfacial structures. It is the center of your face. It is a critical structure for respiration, mastication, vision, aesthetics, and speech. Here we have two images. The one with the blue outline of the maxilla is corrected maxillary dimension to normal, and the one with red outline or orange outline is deficient maxilla. Integrity of the maxilla is very critical for periodontal stability, post-orthodontic and post-orthodontic stability. What we want to happen, we want the maxilla to be the size so we can, to allow axial positioning of the teeth in the bone, in the axial inclination with the opposing teeth. We want the teeth to be surrounded with bone, and we want to have a mutually protected occlusion that will protect the joints as well. So in the image where the maxilla is normal, you can see that the teeth are positioned in the bone axially, and there are no dehiscences and fenestration in the buccal plate. On the other hand, the image on the right with the orange outline of the maxilla, you can see that the teeth, because of maxilla is so small, can no longer be positioned axially. And maxillary teeth, in order to avoid the crossbite relationship with the mandibular dentition, they are flared buccally. And it is quite unfavorable positioning of the teeth in the bone and functionally, that we know very well in restorative dentistry, in periodontics, and how much occlusal trauma it creates, how easily those teeth, susceptible those teeth at this angle are to periodontal breakdown. We also know from the literature that maxillary volume is very critical for post-orthodontic stability, that the teeth that are positioned outside the bone will be less stable, will be more likely to shift and relapse, and the same comes with orthodontic surgery. If you don't get that maxilla right, those cases are going to rebound and they are not going to be stable. So this is a patient with susceptibility to periodontal disease. You can appreciate that his maxilla is much smaller, the maxillary teeth are flat, and when you look at the panoramic X-ray, you will often find that patients with periodontal susceptibility will have more periodontal breakdown in the maxilla rather than in the mandible. So they are going to be more likely to lose the maxillary teeth and need implant reconstruction. And a lot of times, if the teeth are lost in those type of cases, there is nothing left in terms of the implant reconstruction other than sinuses. So you can place your implants in the sinuses after the sinus lifts, but you will have to end up restoring these cases with pink hybrid prostheses and pink porcelain if it's going to be a fixed type of restoration, and in many situations those implants will have to be buccally procline. So it does create at all levels, from orthodontic to orthodontic surgery to periodontal to restorative treatment to implant reconstruction, problems when that maxilla is not addressed properly. In terms of aging, maxilla undergoes most dramatic resorption with aging, and it is a physiologic process. And we know it well from plastic surgery, dermatology, and even from dental implant reconstruction, where we are re-entering implants that were placed in native bone, and years later, because of that buccal physiologic resorption of maxillary arch with age, you see dehiscences and fenestrations, and the implant surface sometimes will be kind of transparent through the gingiva looking gray. So we have seen those cases as well. So I think maxilla plays a critical role. So imagine if you get that patient in a young age in the orthodontic practice, and that child goes through orthodontic treatment, and you give that child nice straight teeth, beautiful smile, but they really needed expansion and didn't do anything about that expansion, it's going to be a problem, because we did not reverse the skeletal problem. And a lot of times these faces are going to age faster. They'll present with accelerated aging and premature wrinkling formation. This is another image from the Journal on Aesthetic Plastic Surgery showing the dramatic resorption along the piriform foramen and also along the zygomatic arches and in the maxilla. So you see these changes every day in your patients, in your practice. We also have to remember that it's maxillary shrinkage is a problem of the modern man. It's a problem that we have gradually evolved to have, and especially the problem became pandemic after industrial revolution. So today, in modern humans, together with impactions of the wisdom teeth, maxilla presents with three-dimensional shrinkage, widening of the mandibular base, as you can see on this 3D image, and also malar flattening. We did not have in 200-300 years ago, short period of time for evolution, only 200-300 years ago, we did not have that many impacted teeth, wisdom teeth as we have today. So those wisdom teeth were in the functional occlusion, presented with wear, and they had room to erupt into the oral cavity. So something is happening to our environment today that does not allow those facial skeletal structure to reach their full genetic potential. So here you have a nice depiction of maxillary shrinkage horizontally in the central slide, and also in the anterior-posterior direction on the outline in blue. On the left, you have a pre-industrial skull where you have a harmony. You don't have like nice overbite. Those humans had edge-to-edge occlusion between the anterior teeth. They had a lot of wear because they were eating a lot of solid foods that had a lot of fiber and created a lot of wear in the dentition. In the middle, you have the picture, the image of one of my patients with severe maxillary deficiency, flat maxillary teeth and mandibular deformity. So if you make the maxilla of the pre-industrial skull the same size as the maxilla of today's patient with deficient maxilla, you can appreciate the changes that are happening at the level of the mandible. And the reason why we are seeing those changes in the mandible, because the tongue no longer has space in the palate to rest physiologically on the palate. So it drops down and it develops mandible in width significantly wider than it should be. The mandible should be contained within the maxillary arch. And this horizontal shrinkage does not only take place horizontally, but also it's happening simultaneously in the AP direction, as you can see on the slide on the left. So we are doing some very interesting research. We are finalizing data from University of Pennsylvania Anthropology Museum on some CBCT scans that we took of the pre-industrial skulls. University of Pennsylvania has one of the largest collections of pre-industrial human skulls. And hopefully within the next 3 months, we will share with you the results of this research. And it's really, really promising, and it's going to change the way we practice orthodontics in the future. The story of hypoplastic maxilla is also very important to discuss. Number one, maxillary hypoplasia is a very common modern human problem. And today it's reaching pandemic levels. So imagine how many, the percentage of children that present with crowding, crossbites, and require orthodontic treatment. All of these children with deficient jaws have deficient maxilla, obviously. Maxillary deficiency is a 3D problem. Usually maxilla shrinks horizontally in AP, and it grows more clockwise and down, so it's getting longer. That's why these patients have very deep, steep palates. It's most commonly underdiagnosed jaw problem, and most commonly because of that not fully being diagnosed, undertreated jaw problem. And the reason why we have this problem is because we do not have a good tool to measure the deficiency. Today we are only measuring deficiency at the level of the posterior teeth, and we don't have analysis to measure the deficiency at the level of the anterior part of the jaw. And also 3D imaging is not available for every practicing orthodontist today, and it has been available to us only recently. So I think once we do more research in this area, we probably will have new analysis. And I have worked on one called 4D morphotropic analysis that is going to answer some of these questions and allow us to diagnose these patients better. The most fascinating point about maxillary hypoplasia is that unlike any other bone of your facial skeleton, unlike mandible, the problem of this hypoplastic maxilla can be fully reversed or reshaped in children and now in adults with skeletal anchorage. So it's reversible. You can address it. You cannot address the mandible. You cannot address the same any other bone of human body, but you can. We have technology to address and reverse maxillary problem in children and in adults today. So commonly, maxillary hypoplasia will also present with crowding. And the treatment for crowding, which is a very common treatment for crowding historically in orthodontics, is basically non-extraction dental alveolar expansion and premolar extraction therapy. So a lot of times those patients are not going to get expanded when they are older, when they present to us too late, and not all of them will accept a surgical expansion option. So many of these patients will get non-extraction dental alveolar expansion with Invisalign, with braces, or when crowding is very severe, they might even be recommended for premolar extractions. Well, none of these therapies, according to the literature today, are going to benefit patients in terms of the respiration and breathing. There is not a single paper in the literature today suggesting that if you do dental alveolar expansion or extraction of the premolars, you're going to improve somebody's breathing. Non-extraction dental alveolar expansion not only presents periodontal risks, and Dr. Rob Lee discussed the bone grafting options for these patients as alternative to preventing and treating those dehiscences and fenestrations, but it also presents a functional problem of occlusal interferences because you have flat maxillary teeth, those palatal cusps are hanging down, and you have flat maxillary canines. They don't give you canine guidance, so all the lateral excursive forces are going on the posterior teeth, rotting them and compromising them long term. And the more occlusal trauma you have on those posterior teeth, when you don't have mutually protected occlusal scheme, the more likely you will have a failure of your dental restorations, the more likely you will have leakage of your restorations, the more likely they will fracture, or the teeth fracture, and then you start with the root canal, with the filling, with the root canal, then with the crown, and then with fracture of the tooth and an implant. So we can do something about this to avoid these problems today. So if you have a child and that child has a bone deficiency and the bone is not growing, and you identify that there is a growth hormone problem, the child is given a growth hormone to address the long bone growth deficiency problem. Well, in orthodontics today, we have technology where we can stretch the bone and we can do non-surgical expansion of the bone, or we can do it with the surgery, such as destruction osteogenesis, such as surgically assisted palatal expansion, or as we talked already, dental alveolar expansion. So we have three options to offer these patients that have maxillary hypoplasia, and there is indication for all, but they also have such as dental alveolar expansion and surgical option, not only contraindication but limitations. And now there still will be a population that will require that surgically assisted palatal expansion, but luckily we are leading toward less invasive protocols such as dome technique and mini SARPI, where we don't have to do such invasive surgical expansion as we used to do in the past. So the focus of today will be non-surgical expansion with MSE, as you can see in the outline in blue, where you are getting that mid-facial correction, where you have sutural opening beyond mid-palatal maxillary suture, extending all the way to nasal bones, all the way to frontal sutures with zygomatic arches. So in orthodontics today, with those bone anchors, with those temporary anchorage devices, we have the technology where we can grow bone without using drugs, without using hormones, without making the osteotomy cuts, and without using the bone grafts. And that technology is called non-surgical destruction osteogenesis, where basically what we do, we apply special orthopedic forces to those bone anchors, and we physically can stretch the facial bones. So the stretching of the bones goes beyond mid-palatal suture. And we can modify that facial skeleton, the mid-facial structures, that we, the same way in adults as we are able to do in children today. And this is the change that you can achieve in the palate, from the palatal view. The blue outline is the patient before and after. You can see that this is the inside shape of the palate outside dental alveolar processes that is completely reshaped. And that change is absolutely impossible with bone graft alone. It's impossible with moving the teeth. That change can only happen if you make a change at the level of maxillary sutures. And that change not only is going to happen at the level of horizontal plane, as we often think of expansion, of palatal expansion, that change is happening three-dimensionally. Not only in the horizontal, you can control the vertical or extrusion of the teeth, and you also stretch the bone in the anterior-posterior direction, as you can see right here. And of course, we want you to send those children to that orthodontist in a much younger age. Our goal is to see these children in the primary dentition, in the early mixed dentition, because that's when the bones are the most flexible. That's before they finish growing. We want to treat these children before they finish growing. And we have all the tools to diagnose these problems in the primary dentition in a very young age. You don't have to wait for the teeth to erupt crooked and blocked out to diagnose the skeletal problem. We have technology today to diagnose this problem in a much younger age, in the primary dentition, before those lower incisors erupt crowded, before those upper incisors erupt crowded, and before those molars erupt in the crossbite. So this is the change that you can achieve. You can stretch the midfacial structures to the point where the teeth are going to be maintained within the bone. The nasal cavity will be stretched as well. And we know if you make a change at the level of the nasal cavity, you decrease nasal resistance, you improve the airflow through the nasal cavity, and you will improve a lot of problems that the patients have today with allergies, with nasal congestion, with nasal obstruction, with deviated nasal septum. Many of these patients will have sleep apnea. So you can make a very dramatic change in these patients' quality of life. And as you can see on this image, the change that we made for this patient with sleep apnea is beyond mid-palatal suture. You have changes in the zygomatic arches, you have better support for the orbits, for the eyeballs in the orbits, you have teeth positioned in the bone to receive axial loading.
Look at the change in the size of the nostril. I mean,
yeah, so if you expand maxilla more than 5 millimeter skeletal, there will be a soft tissue change, but usually it is proportional with the rest of the face, so it's not, doesn't look abnormally wide.
No, I'm talking about the skeletally, the difference between the nasal air passageway and before and after in the 3D.
Absolutely. So this is the patient before and after, 3 years after expansion. The bite is stable. I think her face, her bite is harmonious with together. And also, she recently had her wisdom teeth erupted in full occlusion. So this is her 4 years after expansion, 2 years after we removed her braces, and the bite stays stable, and it was a surgical case. And she has stable occlusion, she has her wisdom teeth in occlusion, and she does not have sleep apnea anymore.
Wow.
So we want to make a difference for these patients. We don't want only to straighten the teeth. We as orthodontists can change people's life, the quality of life at the level of respiration, at the level of getting more oxygen to their brain. So here are 2 patients, 16-year-old 2 patients. Both of them went through 2 rounds of phase 1, phase 2 orthodontic treatment. Both of them spent 6 years in appliances, 6 years of their life when they are growing, when they're enjoying life, they are wearing orthodontic appliances. So the patient on the left has bone supporting the teeth. The teeth are axially positioned in the bone. This patient has canine guidance. This is what you want to see. This is my goal. This is the goal of optimal orthodontic treatment. The patient on the right has fenestrations, root proximity problem. The maxilla was expanded, but it was expanded with 2 supported expander that stretched the teeth, and periodontal ligament didn't do much about the skeletal problem. So this patient can only bite from canine to canine. There is a bilateral posterior open bite because the tongue does not have enough room to fit in this patient's mouth and has to fit between the teeth. So that's something that we want not only to avoid, but we can and should and must avoid today, because we have the technology today to avoid it. So the patient that I just showed you on the left, she did not present to me with an easy bite. It was a severe malocclusion. It was blocked out, impacted canines. It was crowded case. It was thin periodontium case. So we converted this case to something that is going to be more stable, periodontally healthier, and it will be more functional. So we have the opportunity today to make such a difference for these patients. And you cannot make a change like this with braces or Invisalign alone. It's not going to work. Braces and Invisalign straighten teeth. They don't stretch the bones in terms of the opening the mid-palatal suture or other sutures of the facial skeleton. We know and we must consider that limitation. This is another patient. Look at the buccal plate. This patient was a sleep apnea patient. This patient had 2 rounds of ENT surgery with persistent sleep apnea after 2 rounds of ENT surgery. So we had to expand her skeletally to address her crowding, to address her malocclusion, And yes, she did not have a bilateral crossbite. She did not have any crossbite at the level of the molars. And she got 10 millimeters of skeletal expansion. Her sleep apnea is resolved. She doesn't have any more sleep apnea. And we have four sleep studies that we follow this patient with. She has buccal buttressing bone that is going to be there for life. That bone goes nowhere once it's already there. And today in orthodontics, we don't have a single paper that says that with this orthodontic treatment, you're going to have more bone after tooth movement than you had prior. Every single paper, including extraction therapy, including dental alveolar expansion, even including palatal expansion with palatal tooth supported expander, shows that there is a periodontal risk from orthodontic appliances. So the only time, based on the literature today, that you will have more bone after orthodontic treatment if you successfully are going to treat this patient with SFOT. And the literature is still limited. It's very promising, but this is the only literature today that says after this treatment, you might, in the better scenario, have more bone after orthodontic treatment than you had prior, or at the worst scenario, you will not lose any bone, you'll have the same amount. So now we are going to enter a new era of orthodontic treatment where we will have not less bone after orthodontic, but we'll have more, and we will have more bone without doing that SFOT or bone grafting surgery. If we do it with a new protocol and if we do it in the right way, in the right time as well. So we want to build something that is going to last this patient for the rest of their life. I'm originally from Ukraine. This is two buildings that you can find in Ukraine, in my hometown. The building on the right was meant to last no more than 50 years. The building on the left is built 900 years ago without a single nail except the door of that church, and it's still there. So the same principles have to be applied in orthodontics because we are setting the foundation, and the foundation is not in straight teeth. The foundation is in setting up those bones to hold the teeth in the straight position without strain. So what is the case for TED-assisted expansion? Well, the reason why we are using TEDs, am I running out of time? 5 more minutes.
4 minutes.
Okay, so the reason why we are using implants in this type of expansion is because we don't want any periodontal risks to be applied with two supported expanders. And those risks may be in young patients, like adolescent patients, like you can see in this 13-year-old female, or in adults, as you can see in the 31-year-old female. So we want the risk to be taken by the appliance. So if that patient is not going to open in that mid-palatal suture, we want this appliance, the implant, to fail and not the tooth. So that's the goal. So today we have the technology where you can open the sutures in adult patients. And this is one of my oldest patients today, a 64-year-old girl. So you can open those sutures in adults without surgery using those implants. And the result that you are getting is not the same as with the surgery. With the surgery, you are expanding below cheekbone, so you are getting more dental alveolar expansion. So if that patient has very flat cheekbones, flat mid-face, you're not going to give them much aesthetic benefit as you will get with non-surgical protocol. So remember that. So this is my 55-year-old female with upper airway resistance, with narrow smile. You can see a significant wear of her dentition, and she is getting ready for some restorative rehabilitation of her worn dentition. So we suggested MSE. So here you see mid-palatal tori on her palate. So we delivered MSE expander, and believe it or not, one of those implants fractured during placement in the mid-palatal tori. So we didn't stop, we continued, and we still were able to open that mid-palatal suture with opening even the mid-palatal tori. Now we have a nice overjet in the front and the back, so we can upright those lower posterior teeth and give those restorative dentists restorative space with using minimal preparations of the teeth. So now she's almost ready to be set up. And I know Dr. Abli offers beautiful similar setup with Invisalign. I know you can do it with Invisalign, doesn't have to be done with braces, but you can intrude the teeth, you can interproximally space them, so the restorative dentist can restore this patient properly. And look at the change in her smile. This is just from expansion alone. You can see that the buccal corridors are filled, and you don't have to compensate that smile problem of buccal corridors with restorative material. You created with moving bones, not bulking up the teeth. Look at her cheekbone projection. You look at the eyes. The eyes look like she's not squinting anymore. Maxilla will come slightly forward with this procedure. So it is a dramatic change for the patient. And today, you need to have many tools in your toolbox. So sometimes I do SFOT, sometimes I have to do a surgically assisted palatal expansion. But the most important thing that you need to remember, you have technology today to keep those forces off the teeth because of those implants. So you have to utilize those implant-supported expanders in adolescent patients, in adult patients, where you can minimize the pressure to the periodontium on the permanent dentition. So these are two common appliances and variation of both that we use in our practice. So today, in expansion, I think using TADs will probably allow us to achieve better occlusal stability, to avoid or minimize extraction therapy, to avoid or minimize orthodontic surgery, shorten treatment time, and I think for a lot of those cases where you have to compromise with this IPR or less than optimal occlusal finishing with Invisalign, for these patients that need a little bit better result because that maxilla is so deficient, you can offer this treatment and they will accept this treatment to achieve better outcome. So thank you so much. I hope I didn't go over time and we can go to questions. This is my also group on Facebook if you want to follow my work, my email if you have any questions, and always feel free to text me, email me on text me on Facebook.